All right, welcome everyone. My name is Ted O'Connell. I'm the program director at Kaiser Permanente Napa-Solano. Thank you for taking the time out of your very busy schedules to join us for this virtual open house. As we've said in the other sessions, the goal here really is twofold. One is to take a deeper dive into some of the aspects of our curriculum so that you can learn a bit more about our program. And the other intent is to give you a chance to meet some other members of our faculty and our residents. So today's session is going to be on office-based procedures. Our host for this session is Dr. Patrick Lowry, who introduced himself already, but we've had a few additional people join in. So I will reintroduce him. He's a member of our core faculty, has an outpatient full spectrum family medicine practice, works up on labor and delivery, has roles in our clinical competency committee and many other facets of the residency program, does procedures and was just doing procedure clinic this morning with the residents, so that's great. We have a couple of residents joining us today as well, Dr. Vanessa Franco, Dr. Billy Mays, Dr. Haley Winninghoff, and Dr. Ben Denton Schneider. And Dr. Matt Simquick, who is our associate program director, is also joining us today. He can answer, if the topic here today is really focused around office-based procedures, but if anything comes up about hospital-based procedures, he can help add some context to that discussion. Please make liberal use of the chat function here. We're going to give you a short overview of the procedures that we do in the office, and then we'll pivot to Q&A, and we'll use the chat function as a way to jump off and get your questions answered. And when questions do come up, what we will do is kind of sort through them and then ask you to go ahead and pose your question to the group so everybody can hear what the question is. And then whoever's most appropriate to answer it, we will go that way. So with that, I will turn this over to Dr. Patrick Lowry.
Hey everybody, really nice to see all of you on Zoom. I'm in the screen sharing mode and I didn't see how many people were actually on here just a minute ago, so that's great. Thanks for taking your time the day before Thanksgiving. We're really thankful that you are all interested in our program and want to learn more. So today we're going to talk just about outpatient procedure training. We're going to also create a little space to talk about inpatient procedure training as well. We have some of our residents here who will be mainly talking when we open up the floor for questions so you can get their experience. Dr. O'Connell, Dr. Simquick, and I are here to help provide more of a framework from a curriculum standpoint because we want to make sure that all of our residents that come out of our residency program are well trained in office and inpatient procedures. So just thinking about exposures to procedures in your PGY1, PGY2, and PGY3 year, this is not by any means an exhaustive list of where you'd be exposed to procedures, but taking it first year at a time, 1 year at a time. PGY1 year, HBS service, that's what we call our adult hospital family medicine team, hospital-based services, also emergency medicine, labor and delivery, newborn nursing, and then your family medicine clinic. PGY2 year, you have an outpatient surgery rotation, which mainly is in our outpatient procedure clinic, which is staffed by our family medicine doctors, dermatology, orthopedics, in addition, women's health, gynecology month, and also HBS, ICU, and then within your family medicine clinic itself. PGY3 year, you have a lot more family medicine clinic where you're seeing your own patients and being able to do more of your procedures with the patients that you have continuity with. Also with orthopedics and sports, the hospitalist service, emergency department, there's another month there, and then also surgical subspecialties. And then the one thing I didn't add into there is an elective month, which Dr. Franco, who's one of our third-year residents, will talk a little bit more in just a few minutes. We monitor all of our residents in terms of their procedural skills. I serve on the clinical competency committee as well, which is the body of faculty that makes sure that all of our residents are meeting their needs and making sure that they're hitting their academic goals. And by the end of residency, able to graduate as a fully functional, full spectrum family physician. So part of the CCC, we talk about which procedures are required And here's just a quick list of things that we really make sure that all of our residents are ready to go. So, if you come to our residency program, you're going to be able to graduate with these skills and then be able to translate that wherever else you go. Again, this is not an exhaustive list, and most of our residents come through with other training as well for different things, but skin biopsies, cryotherapy, abscess INDs, sebaceous cyst removals, ingrown toenails, injections, aspirations, Nexplanons, IUDs, pap smears, cervical cancer screening, which we're really saying now, vaginal deliveries as well. And then residents that might have a keen interest in other areas are going to be ready to go in different areas too. But these are the core procedures that we hold all of our residents accountable for and make sure that they're ready to go. I want Dr. Simquick just to pop in real quick to talk about hospital procedures, because I think when we're talking about office-based procedures and going into it, if you're okay, Matt, just noting real quick, in addition to ABGs, thoracentesis, paracentesis, central lines, when you're in the ICU, point of care ultrasound, anything else we're missing in terms of our residents there?
From that list, probably just LP, right?
Okay,
So
lumbar punctures, yes.
On the wards, lots of paracentesis, thoracentesis, definitely a lot of bedside ultrasound, and then lumbar puncture, probably make up the majority of what we do on the floor, and then the others, as you mentioned, in the ICU.
Perfect. Thank you, Matt. So I want to give our residents a quick moment to discuss what their experience has been with procedures and procedures that they feel really comfortable in. And we'll start with Dr. Mays. And do you mind just introducing yourself, where you went to medical school, and then what your procedure experience is? And then after the residents go through and give you a quick little blurb, then we'll talk more and open it up to questions.
Patrick, I'm not sure that Billy's on here yet, so maybe we can start with one.
Perfect. In my Zoom screen, I only see 6 of us, so it's hard for me to say. We'll skip right to Dr. Vanessa Franco then.
Hey, hello, everybody. Thank you for being here. So from that list that the Dr. Lowry showed, I pretty much have done everything and in great numbers. One thing that I really love about the program is that we have that 1 month dedicated to what we call patient surgery-based procedure clinic. Because I believe that in other programs, you get the procedures as they show up in your clinic, and then it's kind of hit or miss. While we have like a whole month where they only booking procedures. So you see all the toenails, all the INDs, all the biopsies. So you really get a lot of practice there. And we also have a few months where we do only gyne procedures. So we get very comfortable with those. And as Dr. Lowry has said before, I chose to use one of my elective blocks to do an extra procedure clinic block, just to get like on the ball with my skills. And, I particularly love procedures, and I feel very confident at this point in my training that I could do those, most of them without supervision when I graduate.
I can attest to that as well, as I work with Dr. Franco with doing lots of procedures. Though we don't have any of our residents do these procedures on their own unless they're signed off and demonstrate competency. We as faculty are there to support people along the way. Next, we're going to go to Dr. Haley Winninghoff, who I worked with in procedure clinic yesterday, I believe. Was it yesterday?
Yesterday.
Time flies.
Hi, everyone. Thanks for being here again. I think I don't necessarily have a whole lot to add other than what Dr. Franco Vanessa mentioned. I'm currently in my 2nd year and I'm a week and a half into my office-based surgery rotation, which has been awesome thus far. And I would say even just in a week and a half, I think the number of times and repetition that we get the procedures has been extremely helpful. just kind of from a perspective of when the other times we get some exposure to some of those procedures, I certainly just in my routine family medicine clinic have also done a good number of INDs and Nexplanons, as in addition to when we're up on the OB floor, we do a lot of Nexplanons with postpartum care. And then otherwise just kind of routine women's health pap smears. We do a lot of toenails occasionally will come into our routine clinic as well. And I think and joint injection. So it's a really nice way to kind of, I've had a sprinkling in the last year and a half, and then now I'm having a lot more repetitive training, which is really helpful in terms of gaining skills and comfort. And I think already feel a whole lot more comfortable than I did a week ago. And still have another 3 weeks of this rotation and then another year and a half to work on more and more. So very excited for that. I, like Dr. Franco, also really enjoy procedures and certainly envision them being a core component to my practice in the future.
So I just want to stop everyone and reflect back on yesterday, and I'm just looking at Dr. Winninghoff's schedule. And so she started the day, she did procedures all day yesterday, and she's doing her second year 1 month intensive of outpatient surgery, which is essentially in our procedure clinic. So yesterday morning, I'm just looking over at my screen here. She had a toenail removal. She had a biopsy of the face, a biopsy of the arm, a biopsy of the cheek, a shoulder injection. And then I think there was an abscess drainage, and then another ingrown toenail removal. And then she had a boil abscess drainage, a wart removal, a cyst removal, a physical exam sprinkled in there, and then another ingrown toenail, which looks to be bilateral toes. So that was her day yesterday. My morning today of procedure clinic was pretty eventful as well. I had a sebaceous cyst removal. I had a bilateral knee injection. I had a trigger finger injection. I also then did what was going to be a wrist injection that turned out not to be that. And then sort of a wart pairing and cryotherapy, and then a toenail and an IND. So that's what you're getting on a daily basis within our procedure clinic, and you're going to feel confident in those things. Dr. Denton Schneider, are you on the call?
He is not on yet.
Perfect. So that's a flavor of what you're going to get from our experience here. And interestingly enough, I have to share a story, an anecdote, a part of the reason why I work here and why I work with our residents. So I trained at San Francisco General at UCSF, and part of our exposure in terms of starting our residency program, as I was finishing the end of my residency program, I actually came up to Kaiser Vallejo at the home of our program that still had yet to be started, and we're still working on that. And I did a lot of my procedural training here as well with one of our core faculty who has since retired. And this was a place that I realized that I could actually work and that I felt really comfortable in the training that I received. And since then have worked here for the last 7.5 years and think it's a really amazing place to work and train family medicine physicians. And so if there's any questions now, I want to open it up to the floor to say, who has questions about procedures? And if you have questions in the chat function, feel free to put it in the chat. And then Ted, do you mind moderating in terms of like who's up next in terms of questions so we can keep everybody in order?
I will be happy to do that. And I may even direct them to particular individuals or throw them out to the group. I'd like to start, actually. I got an email from one of the applicants who's on this session today. So Mary, if you don't mind posing your question to the group.
Sure. Yeah, so I was just wondering, during the pandemic, have you had a decrease in the volumes?
Oh. Can we just stop? When you ask a question, do you mind just introducing yourself first so we know that where you're from?
Sure.
I apologize to cut you off.
No problem. So my name's Mary. I'm at the University of Toronto, born and raised in Toronto, but my mom's family's from Western New York. So my question is just regarding the pandemic. So have you had a decrease in the volume of patients coming to your procedure clinic, and has that interrupted the number of exposures? I mean, based on what you said, it sounds like there are pretty full days, but has that interrupted exposures and experiences in gaining competencies in procedures? And then how would you mitigate that if yes?
Yeah, great question. So I think you got to take it back to the beginning of the pandemic. When we shut down in March, everything sort of grinded to a halt, and we really weren't having any patients coming in, except for people that really needed procedures because people have an abscess, a toenail, those sort of things can't really wait. So we were able to use our flexibility with our residents to open up a lot of those procedure slots. What really got pushed to the side was more of the well child exams, the annual physical exams, but procedures need to get taken care of. And sort of the elective sebaceous cysts necessarily weren't coming in, but people that have, infective abscesses, those sort of things, they were still coming in. And right now, it actually interestingly gave us some leverage that we actually have more procedure time for our residents going forward. And we're staffing our procedure clinic through the entire department, of which consists of approximately 70, family medicine docs and other internists that do primary care. And so we are fielding all those procedures for the entire catchment of the patients that we serve. So great question. Matt, do you have anything to say?
Yeah, one of the, I think one of the strengths of our program is sort of adaptability, both within our group in the residency, but also within the medical center. And we have seen, a little bit of a decline in the volume of face-to-face visits in favor of virtual visits for our residents. And one of the things that actually we're doing kind of right now over the winter is we're increasing the number of procedure clinics that the rest of the residents are assigned to do. So rather than just the resident like Haley, who's on her outpatient surgery month and doing mostly procedures and her continuity clinic, we kind of sprinkle in everyone else into the other half days where Haley is either in continuity or doing other activities. So that's been super effective at just kind of increasing the volume of face-to-face care for our residents. And then of course the bonus of extra procedures. So
great, thank you.
So our residents are now basically doing almost all the procedures in the department. So.
Yeah, just to chime in quickly, if anything, I've had more procedures in the last 6 months, even leading into just in my normal clinic days than I did prior, just because we're getting a lot of the in-person visits. And so we're fielding a lot of those things.
Patrick, just to make you aware, I'm checking on the group chat and answering questions that show up there if you don't hear that.
Dr. Franco, you're amazing. Thank you.
So there's a good question here from Perina about when residents start doing procedures, and I'll ask her to pose this question because it was a three-part question, and it actually, I think, dovetails with another question from Adam Villa about a simulation clinic. And I think it's a nice chance to talk about our clinical skills month a bit and how we work really hard to make sure all residents, when they hit their clinical rotations, are really ready to take on those experiences. So Perina, do you mind posing your questions to the group?
Yes. Hi, everyone. My name is Perina. I'm calling in from University of Arizona in Phoenix. Have called Phoenix home for many years now, but originally from northern India in Punjab. My question, say for you, is I'm curious to know when do the residents start doing procedures, if it's during intern year, and what does that initial training look like to get them ready to do the procedures?
That's a really great question. The short answer is you can have a procedure your first clinic day. And so we will be training you and you'll be working with your preceptors to help you. But I think this is an important piece to bring in our clinical skills month that all our residents go through at the beginning of their intern year, the beginning of their second year, and the beginning of their third year. I know in theory more about our clinical skills months than in actuality because I don't actually go through it. So I'm going to turn this over to Dr. Franco and Dr. Wienenhoff to share their experience with clinical skills month and what they've learned.
And Billy Mays has joined us now too, so we can have his input as well.
Welcome, Billy.
So I put it on the group chat a minute ago. Another thing that is different about our residency program. Every year, when you first start your residency year, be it intern year, second or third year, we have the first month as our clinical skills month. So it's a whole month that's dedicated to, training and practice. And for the first years, you're going to have practice on suturing. We're going to have practice on Nexplanon placements. We had this year a very good session on point of care ultrasound as well. So you get some of the practice in place, you review technique with some of the faculty, and then, like Dr. Laurie said, you may have a procedure on the very first day of clinic, but of course, based on your level of training, the preceptor for the day will always come with you to the procedure. Most of the times, if it is like only the procedure that you're doing on that clinic, like somebody that comes in with an ingrown toenail, you're going to discuss with the preceptor the technique before you go into the room to perform it. So and then as you progress and after you have done so many, faculty can sign you off saying that you can pretty much do the procedure on your own, but they always been supervising. Like the difference is that how hands-on the help is as you progress. So that has been my experience.
Great, thank you. Haley and Billy, did you want to add any more context to that?
I don't think I have a whole lot to add. I know there was another question that came up in the chat box that I think is similar to this. Do residents start with relatively simple procedures and graduate to more complicated ones, or is training based on what is available during rotations? So yes, I think more the second. We start with whatever shows up, whatever walks into our clinic, whether that's a toenail or a joint injection or some sort of abscess. I know I actually this year, but ended up with a very, very large vaginal abscess, and I had never done anything like that before, and just kind of walked through everything and jumped in and we did it. And it was, it's all learning, and we have lots and lots of support with the preceptors who are with us. And sometimes you can't predict ahead of time, and so sometimes you can't prepare ahead of time, and sometimes you can and really do more learning. And so we kind of take it as is with each experience. Certainly, I think some of the procedures we get a whole lot of our first year are Nexplanons. We do a lot of those when we're up on the OB floor. And then otherwise, I think it's fairly random, and partially that's just because we have less time in clinic. And so the number of actual patient encounters in our home clinic is fewer in our first year. And we have more opportunity both in the emergency department and on inpatient medicine to get procedures in our first year, and then associated with obstetrics, and then whatever walks into our clinic. But certainly a sprinkling of those. I think in terms of training, just to give a little bit more of a sense, the procedure clinics that we do in our clinical skills month are often kind of co-taught by family medicine faculty and then other specialists. So our recent session that we did this last year on injections and point of care ultrasound for shoulders and knees was co-taught by sort of a sports medicine physician and one of our family medicine faculty. And so that kind of gives us various perspectives and kind of really great teaching. Similarly, for our obstetrics training, we tend to have that as well in terms of those procedures. And kind of suturing and vaginal laceration repair, that's something that we spend a lot of time on. I think most people coming into residency haven't had a lot of exposure to that. And it can be one of those things that's just very hard to visualize and kind of hard to grasp initially. And so we spend a lot of time both proceeding when we were first on the OB floor, and then also up there, our first couple of lacerations, a lot of kind of just having a second set of eyes and assistance with that. So I hope that is more information, but happy to answer any more questions as well.
That was great, Haley. Thank you. There's a question here from Harini about point of care ultrasound that I'll ask her to pose to the group. I think it's a chance to talk about ultrasound for prenatal and OB and inpatient and in the emergency department and in procedure clinic and in orthopedics. I think we can actually talk about it in multiple venues. So Harini, go ahead and pose that question, please, if you don't mind.
Sure. Hi, I'm Harini. I'm from New York Medical College. I just wanted to ask about the process of POCUS training for residents here, how comfortable residents get with ultrasound, and what's the scope of use in the residency program.
Thanks for asking that question. That's a really great topic, and I know a lot of people are really interested in point of care ultrasound. Dr. Mays, are you able to jump in and talk about your ultrasound experience thus far and what you've used it for? And then I know then I'm going to bring in Dr. Franco again, because I know her and I use the ultrasound quite a bit.
Can everybody hear me?
Yes.
Woohoo! Sorry I'm late, everybody. So I am on the second year gynecology clinic month. So the reason I'm late is because I was doing transvaginal ultrasound for a bunch of my patients up there this morning. So I'll kind of touch on two things. One is that during our gynecology clinic month, we get a lot of procedural training within that. And it's actually, the setup is awesome because we work with many of the OBGYN attendings on labor and delivery during our first year. And so we're familiar with them and they're familiar with us. And then we work one-on-one with them in the gyne clinic. And the way I've been approaching it is just like, I want to get good at placing IUDs. And so I sort of scope the whole schedule for all the OBGYNs that are in clinic in the morning. And if there are procedures that I really want to do or patients that I really want to see, I just go up to them and ask them. And they all know me and feel comfortable with me. And so I'm able to kind of cater my training to what I want to get out of it, which is awesome, I think. And then, yeah, in terms of ultrasound training, like I said, we're doing like transvaginal ultrasounds all the time. On labor and delivery, we do transabdominal ultrasounds all the time. We're like, dating pregnancies. We're measuring size of fetuses. We're like, doing amniotic fluid assessments in terms of like prenatal and OB care. And then, we're very lucky in this residency to have access to like high-end ultrasounds in our clinic, in our continuity clinic, and we have butterflies available, which are the probes attached to the iPad setup. And we have two of those. We have one for our clinic and then one up on HBS. If we have more, Ted, feel free to jump in, but I think
we have 4 of them.
We actually have 4. I've never had a problem getting one. So, so those are available for us anytime. Basically, we just go up and grab it and we can use that to like, if somebody has a lump and we want to see if it's an abscess or not and there's fluid under there, we can do that. We can do, on our inpatient medicine service, I use it a lot to do like quick, like fast exams. And I think it's especially useful for cardiac ultrasound, getting a sense of like central venous pressure, IVC measurements, and then just like getting a gross sense of pericardial effusions and ejection fraction of the left ventricle. So, and you can sort of incorporate it as much or as little as you want. And I think we're very lucky to have all those resources available to us.
Thanks, Billy. Does anybody else want to add to what Billy's already had to say? Okay, I think you covered it then, Billy. So how about Kristen? There's a question about like focusing on certain procedures versus exposure to all. Do you want to ask that question, Kristen?
Yeah, hi, my name is Christine and I'm a student at Tulane. I'm from Bellevue, Washington. So my question is like during the elective month, like are residents able to focus on certain types of procedure, or is the elective opportunity meant to be just increased exposure to all procedures?
That's a really great question. Thanks for asking. Dr. Franco, do you want to field this question?
So sorry, I was trying to catch up with the questions on the group. So what was the question?
So the question is, in your elective month, did you focus on any specific procedure, or are you focused on all procedures in general that were coming in?
So I think in part I can explain to you a little bit the history of our procedure clinic, so it will make you, I think it will be easier to answer the question this way. Long time ago, here at Kaiser Vallejo, some of our subspecialties like podiatry, dermatology, emergency medicine, and orthopedics, they start getting like really swamped with those small procedures, and it was causing delays on the specialists to see to see more serious cases. So the procedure clinic was created in part to relieve the times on the specialists, and also wonderfully for us to train our residents, right? Because those are all procedures that can be done by family physicians and don't need to be routed to specialists. So what happened is when you're in procedure clinic, our members that need procedures will talk to their primary care, and they will be booked for us to see. So you don't necessarily choose like, oh, today I'm only going to focus on biopsies, or I'm only going to focus on injections. You do a mix of a lot of things. The only thing that kind of gets separate is the GYN procedures that you're going to get to do on your regular clinic during your gynecology month. You're going to do lots and lots of like pap smears and IUDs and EMBs. And then when you are on, I think, second year as well, I know third year for sure, when you were in a lighter rotation, some of your Fridays get dedicated to GYN procedure clinic. So it's a procedure clinic, but it's GYN based. Does that help answer your question?
Yeah, for sure. Thank you, Dr. Franco.
So I think it's important to talk about, if you're going to use your elective time during your third year to focus on more procedures, you can tailor that to how you want it to be. If you're hoping to be more involved in just doing procedures in general, having more procedure clinic time is there. We have a women's health procedure clinic that's on Friday afternoons, and it's a half day of just focused on women's health procedures, Nexplanons, IUDs, manual vacuum aspirations for, a missed abortion or a spontaneous abortion, for miscarriage management. And that's was born out of the fact that we've had some residents in years past graduating, and they wanted to get some more women's health procedure time. Now, during your elective time, if you wanted to focus more on just women's health procedures, you could do elective, spending more time in the gynecology clinic and get exposed there more. But now we actually have a dedicated space for all of our residents to rotate through to get focused women's health procedures. And then when you're in that clinic, that's really what the focus is, as opposed to putting in an IUD at the same time as a toenail. But our procedure clinic in general is open to all procedures, and it's whatever the needs of the patients are.
Great. Thank you, Patrick. And I think it's also worth noting, we did another session entirely dedicated to women's health procedures. So if you have an interest in learning more about that scope too, you can go take a look at that one, which we've saved through YouTube. There's a question here from Abigail about training to do scopes. Do you want to ask that question, Abigail?
Hi, my name is Abby. I'm from the University of Arizona College of Medicine in Tucson, and my question is whether there are opportunities for residents to train in doing endoscopies or colonoscopies, if any have done that already, and if there are any faculty available to do that type of training.
That's a great question. To my knowledge, none of our faculty are actively doing any colonoscopies or endoscopies. That being said, if we had a resident that was interested in doing those things, that there would probably be an opportunity to do elective time with our gastroenterology team to get into the endoscopy suites to get more of that experience. Years past, we had a few of our family medicine docs who were trained in colonoscopies, endoscopies during their residency, and they were doing that. But to my knowledge, that's been phased out, and the specialists tend to do those within our system specifically. But that doesn't mean that there wouldn't be an opportunity to help support a resident that was interested in those procedures.
Yeah, I'm happy to add a little context to that as well. I used to do flexible sigmoidoscopies for the first 5 or 6 years of my career, and those just kind of have gotten phased out as a main mode of screening for colon cancer, and have been replaced by either stool-based tests or colonoscopy. And I've had this question over the years and actually asked one of our gastroenterologists quite a long time ago now. And his response was, sure, we could train a resident who's interested. However, in order to get credentialed after graduation, because it's an inpatient procedure, you have to go through a credentialing process. And in order to get credentialed, or if you're not with, if you need to get insurance outside of a Kaiser Permanente facility, that the expectation would really be 200 colonoscopies that you've been precepted on. And that's all, you would be dedicating probably all of your elective time to get to something like that. So if, for a rural-based practice, there may be some utility in that. Our program, though, has tried to focus really on the core of family medicine. Family medicine is already really broad, and we think our scope, have really embraced a full spectrum training. It's just at the end of the day to also get you trained in upper endoscopy and colonoscopy is really kind of an extra thing to jump over. So I think our gastroenterologist would probably be open to it if somebody wanted to, but that's not part of our base training. There's a question here from Stephanie about getting signed off for procedures.
Great question.
Stephanie, are you on? And
I'm here. Yeah, I wasn't sure if you wanted me to.
Yeah, great.
Okay. It's a chance for us
Hi.
to say hello also.
I'm Stephanie. I'm from Berkeley, California. Nice to see all of you. And thanks for continuing to have all these sessions. My question is mainly just at what point in residency people tend to get signed off on, like, for independence, if that happens, I'd imagine typically later on, and just on average, but also specifically for LARCs like Nexplanon and IUDs.
Really great question. Thanks for asking, Stephanie. And that falls in the purview of more of our, clinical competency committee, and that's a group of our faculty that monitor resident training and making sure that everyone's meeting the standards and meeting proficiency in all the goals based on the ACGME requirements for family medicine. I would ask one of our residents to chime in here and maybe walk through a process of them actually doing procedures, and then what is the steps that they take to actually get signed off to prove their competency. Does anyone want to jump in? Vanessa, Billy, or Haley?
Sure, I can. I've been signed off on a few things. I think part of it is, I'll just speak to the general process. Once you've done a certain number of procedures, and I think it varies per type of procedure that you're trying to do, you ask one of the faculty members to sort of observe you formally doing that procedure once you feel competent and you've met the numbers, and then they go through the checklist of all the things that you should be doing with that procedure. And then as long as you're doing the procedure adequately, you can get signed off on doing it. And they just give you, it's actually really nice because they give you a lot of detailed feedback and things that maybe you weren't explicitly thinking about that you should be doing for each procedure. And that's how you get signed off. And then you can essentially do those procedures independently after that. I've been signed off, like I can do Nexplanons independently now. I can do like joint injections, biopsies, toenail removals, all those types of different things.
Yeah, so Stephanie, that's actually that's a very nuanced question. There's a couple of factors at play. As Billy referenced, we have guidelines on how many procedures roughly you should do before you ask for a competency evaluation, with the understanding that, if our suggestion is 10 for a particular procedure, one resident may feel really comfortable and competent after doing 6 or 7, and another one may need 15. And that's all about individual learning. And that's why it's just a guideline. And then once the resident has done a certain number and had that competency evaluation, it goes to our clinical competency committee to actually look in and see that they have documented their experience doing a certain number of the procedures, so that we don't get somebody asking for a competency evaluation on their first attempt and that attending just not being aware of it. So there's kind of quality controls built in. The second piece of it is we sometimes do have first-year residents who get enough of a particular procedure to be signed off for competency. The ACGME expectation is that all intern procedures are proctored, or actually I don't actually know if that's a requirement of theirs or if that's how we outlined it in our procedure guidelines. So a first-year resident can get signed off The expectation, though, is that all procedures in the intern year are supervised. And then once you hit the PG2 year, the supervision guidelines change. So I hope that answered your question.
Thanks for adding that, Ted. Those were all the touch points I was going to put in there. I was actually going to put in our procedure competency checklist that we have that's available in our precepting rooms. It's available up on labor and delivery. So when residents are approaching that, they're thinking that they're gaining competency, to ask that question. And just because I'm going to use Billy as an example, he was ready to sign off on Nexplanons, but we review as the clinical competency committee every month residents that are approaching competency, ones that have asked for permission to get competency, and we review their forms and we review their numbers, and we have all of our residents starting, the first day of intern year, tracking their procedures, so we know how many they've done and did we feel comfortable and do they feel safe performing those procedures. But even when our residents are signed off, our workflow is that we're here as faculty to help precept, and so when you're doing a procedure, we want to be there with you, with the patient, so we can help one set up, be your assistant, give you some nuanced guidelines in terms of, I would do this maybe a little differently, and push your learning a little bit further. So really great question. Thanks for asking.
One thing that I would like to add, I put it on our chat as well, is that like when you're in procedure clinic, you're kind of spoiled because you have a one-on-one like faculty mentor, because, most of the procedures they will be either assisting or supervising, so you don't have to wait to precept. So you have somebody that's always there to assist you. And even if it's a procedure being signed off in, but you're not feeling very hot that day, or you like have a question, they're right there to help you out. I would like to ask a question here for Marianne, because she posted this and I couldn't really answer. She's asking in pre-COVID times, when we do our global health rotation, our trip to Honduras, if procedures are done on that setting as well. Our class, COVID. So whoever could answer that for me.
Great question. Dr. O'Connell or Dr. Simquick, do you want to field that question?
Let's let Matt Simquick answer that, because I've been there once to Honduras and he's been there multiple times, and I think that's an easy one to answer.
Yeah, absolutely. We'll do any procedures that we are competent at, that anyone in the community needs, honestly. And Javier Sevilla, our partner from Indiana University, actually sort of scopes out procedures a week or so ahead of when we come. We've done, well, the legendary procedure was Ethan Sellers and Kelsey Goodwin removed a very large, very, very large lipoma. A very large lipoma from the back of a patient, and did a phenomenal job. But we have, pictures of them, not him, in action, that you'll see actually in our website and on some of our slideshows. So definitely, and introduction of the butterfly and the POCUS in Honduras in 2019, and plans to incorporate going forward, certainly.
Great, thanks, Matt. There was a question here that I'll just kind of take off the list. Adam had asked a question about, do we break it up into peds versus adults in the procedure clinic? And Vanessa answered that question in the chat. We take all comers, but it's pretty much regardless of age. And so you'll end up with a blend in those clinics. There's a question here from Tristan about block rotations and where procedure clinics and gyne procedure clinics can fall. So if you don't mind asking that question, Tristan, I think that's a good one.
Sure. Thank you for having this presentation. I think Dr. Franco did a good job of answering it, but I guess I know there is dedicated didactic time, and I wasn't sure if there's an analogous time for procedures that's more longitudinal throughout the curriculum. So are they specific to each block, or are they like longitudinal, notwithstanding the procedure clinic month?
Great question. So I want Dr. Simquick to chime in here as we sort of adjusted some of our schedules and opened up more procedure clinic time for our residents. And Dr. Simquick, what rotations are we primarily scheduling the extra procedure clinic time for our residents?
So they're actually really in every procedure. I mean, every rotation throughout the second and third year. And it was pretty arbitrary, actually. So second and third year residents tend to have more clinic, than first years. And it's just easier to kind of schedule them for additional procedure clinics. But just to repeat, the way a patient gets into a clinic appointment can get, can have an R1, a PGY1 scheduled for any of these office procedures that we do in the clinic. So it's pretty, like, in terms of, is it longitudinal? I think in effect, it is. The residents are doing at least these office-based procedures throughout, any and most blocks throughout the training.
I just would chime in there and to understand part of how family medicine works in residency. You have more family medicine clinic time the further you get in your training. And so with that, when you're scheduling your own patients to see, oh, I have my primary care patient that needs X, Y, and Z. Once you have more competency in performing procedures, you don't necessarily need to rely on the procedure clinics, the women's health procedure clinics, the gynecology clinics to be able to do those procedures for your patients. Because if your patients have a need, then you're going to feel comfortable to bring them into your office, and you're going to do it just like a regular old visit. My 9:30 this morning happens to be an EMB and a pap smear and an HPV screening, and we may or may not put it in a Mirena IUD depending on what the needs of that patient are. And that's just all things that just then flow seamlessly into our clinic. But the dedicated time to learn and hone your skills and feel comfortable is there. So then you feel more confident embedding actual procedures into your clinic, because I would venture to guess that most family medicine physicians that are practicing in a busy outpatient clinic are just mixing them in. They don't necessarily have that standard time that we give our residents. It's nice when you do, but in order to maintain doing lots of procedures, I do all of my own patients. I try to do them myself and try not to then pass them on to other people to do. And that's what we encourage all of our residents to do as well. Great question.
I was going to say the same thing, Dr. Laurie. Like, at this point in my training, if I have a patient that needs a pap smear, I'll send a message to my medical assistant, say, hey, book with me for pap smear, book with me, for abscess IND in my clinic. But we have this dedicated monthly procedure clinic, which to me is a great opportunity to learn all these skills, other than just relying on, oh, how many, like maybe you got 12 toenails in your first and second years and somebody else get like all the INDs. So in this manner, everybody gets trained and competent in all the different kinds of procedures, and then you can do it in your clinics when you get more comfortable with them.
Great, thank you, Vanessa. And I've been looking at the chats, and it actually looks like Vanessa's doing a very good job of answering most of these questions. I do want to be respectful of our residents' time and their afternoon clinical obligations. So I think what I will do is just there's one other good question here. I think it's really important for applicants to really have their eyes open about any residency program and see the really great aspects and the aspects where maybe there could be some improvement. And so I want to pose, I forget who asked this question. I think it was Marianne asked, are there any procedures that you would like to have more of? And I think that's a good question for all of the residents to chime in on. So Marianne, do you want to pose that question?
I actually don't think it was my question.
Oh, I'm sorry then. Okay, then I'm going to fake propose it because I forget. I got lost in the chat here. So the question was, though, to the residents, are there any procedures that you would like more of, or you don't feel super comfortable with where you are? And I think it's also important for each resident to remind us where you are in your training, because there will be additional opportunities if you're not at the end of your training.
Yeah, I'm happy to start. So I am Haley again. I'm a second year, so halfway through, and am not quite halfway through my procedure month, my outpatient procedure month, and I have not done my gyne procedure month yet either. And so I think one thing, I guess, and up on the screen we have vasectomies. I actually, of note, I've been recently talking to a few faculty about that. Vasectomies are certainly something that is done in some primary care settings, and at Kaiser, historically, they've been done a little bit more with the urology department. So I think that is something that I'm interested in, and I know I've talked to 2 of our faculty who do them and who are involved in gyne, and we're actually working on seeing if there might be a way to get some training. So I think that's one thing that is really lovely about this program, is that it's very dynamic. There's lots of opportunities for growth, and if you express interest, usually there is an opportunity in a way, kind of like with the endoscopy and the colonoscopy, to get some of that training. I would say at this point, I feel like I would really love a lot more women's health procedure training, and I think I will get that next month. And so I think I may feel differently after that. Certainly I have had a good sprinkling just in my normal clinic, and I've done some family medicine gyne clinics. We actually have those intern year, and I've done a ton of Nexplanon insertions and removals, and a ton of pap smears, but fewer IUDs that have just kind of rolled into my clinic. And that, I think, is just kind of a give or take situation. And then certainly in terms of a kind of abortion, abortion care is a kind of another thing, and that's in gyne. We, I think, probably touched on it in our gyne video. But miscarriage management, I have not done a whole lot of that yet either. And so really looking forward to that.
Vanessa, would you like to jump in?
So Haley, at least it happens differently for each one of us, but at least on my month of gyne clinic, on my second year, I had a ton of procedures done that. And then I had the opportunity to do, some of medical abortions with the practitioners there. And I now, like after that month in particular, I feel very confident with my IUDs. The pap smears I had done, I've been lucky in the sense that I had many my first year in my clinic. So I kind of feel confident with that one too. But yes, I agree with you. Like I feel that I haven't had as many opportunities to do like the abortion care, but maybe because we just don't have the volume, I guess, in our clinics then.
Perfect. Billy, did you want to weigh in on that at all?
Sure. Yeah. I think I feel after our like surgical clinic month, I feel good with pretty much like all lacerations, toenails, skin biopsies, and injections, and INDs. I think similarly, and in terms of women's health, I feel very confident in pap smears and transvaginal ultrasounds and Nexplanon insertion and removal. I think the thing that I want to get more out of women's health is definitely IUD insertions. And then in terms of other procedures, I've done 1 paracentesis, 2 thoracenteses, and 1 lumbar puncture. And I would like to do more of those things also.
We'll make sure that happens for you, Billy.
I know.
All right. So with that, I'm going to wrap us up so everybody can get to their clinical duties. I want to thank our residents for taking the time and giving up your lunch hour to join us and talk about the residency program, and to Patrick for facilitating the session, Matt for being here, and to all of our applicants for taking the time out of your schedules to learn a bit more about us and what we're up to around office-based procedures. Patrick, did you want to say anything as we wrap up?
No, I want everyone to understand that, we are committed to training our residents to be excellent full spectrum family medicine physicians. And we are so thankful that you are taking the interest in us, and we wish you all a really happy Thanksgiving.
Great. All right. Thanks, everybody. Have a great Thanksgiving.
Thanks for coming.
Thank you.
Thank you, everyone.
Thank you, everyone.
Happy Thanksgiving.
Thank you.